The broadcast is now starting. All attendees are in listen-only mode.
All right, hello, hi everybody. Hope everyone is doing well. My name is Tal Lee. Welcome to our secrets of the USMLE, how to dissect any question on test day. Let me get my screen ready here. Sorry about that. All right, now presentation mode. Okay, there we go. Great. I'm the editor of First Aid and USMLE-Rx. I'm also an associate clinical professor at University of Louisville and section chief of allergy immunology there. We got a couple of folks with us tonight. The primary presenter is Dan Griffin, from University of Missouri. So I want to introduce him. Dan, would you like to introduce yourself?
Yes, hey everybody, it's Dan here. I've been working with First Aid for 2 or 3, 4 years now. I'm currently the editor and author of the USMLE-Rx Express videos. Been really enjoying the project and also enjoying the, how to dissect questions on test day and our little secrets of the USMLE thing here. Been a lot of fun and like I said, currently a pulmonary critical care fellow at University of Missouri at Kansas City.
Great, fantastic. Now, I also see we have two panelists that will be helping answer questions with Dan tonight. First is Sean Nanji. Sean, would you like to introduce yourself?
Yeah, hi guys. My name is Sean. I'm happy to be on this webinar with you guys, and I'll be answering your questions. So hopefully, if you guys have any, I'll be able to answer them for you.
Great. And then we also have Manaver Dio as well. Manaver?
Hi everybody. Welcome to the webinar. Ask away. Ask any questions you have, and we'll be happy to respond.
Great. So we have a question panel on the right side if you're on a PC or a Mac. So you can type your questions into the question panel. We also have, and so what we'll try to do is we'll try to answer as many questions as we can. We can't guarantee that we'll get to everybody's questions just because you guys outnumber us by quite a bit. There's hundreds of you folks on the webinar tonight, but we'll do our best. And certainly, we'll let you know how you can connect to us through social media, through Facebook and Twitter and Instagram and so forth at the end. So if you want to continue the conversation, we'd be happy to try to, help you through our social media channels as well too. So with that, let's get going with the presentation. So I'm going to, move on here. So again, in the next hour or so, we're going to be, going through question types. We'll talk about the anatomy and board style questions, what you need to do to dissect questions on the USMLE. We'll spend actually the majority of our time doing question dissections. We'll wrap it up with some advice at the end, and there will be a raffle and some special offers, as well for those of you folks who, stick with us through this webinar. And then at the very end, we'll open it up for some Q&A as well. Okay, so as you may be aware, the USMLE Step 1 is made up of single best answer items, question items. So that means you'll get a question, you'll get 4 to 5 to 6, maybe occasionally 7 distractors or choices to choose from, and you are looking for the single best answer. Sometimes there are answers that may be partially correct, but what you're always looking for is the best correct answer. A few of these items will have multimedia. Most of them will have clinical vignette, which makes up more than 80% of the exam. While there are a fair number of single-step questions, I would say you need to be prepared to do multi-step questions. And what the multi-step questions is, it integrates multiple different concepts or disciplines that are related together. So, for example, here's an example of a simple 2-step question. You have a 32-year-old woman Caucasian woman who presents with a 5-day history of occasional double vision and bilateral ptosis, and then that's the stem, and then that's the case, and then what it does is ask you what is the most appropriate diagnostic test. Let's see. Just a really quick question. Somebody's saying they can't see my screen. I've got it presenting. Looks like other people can see it, so I will keep going. So anyway, So the question, what is the most appropriate diagnostic test? So you'll note right away that when you look at it, oops, wrong thing. I do not want to print this. Let's get back here. The arrow here is that what you'll notice is that you're presented with you have to make a clinical diagnosis first. And then in this particular case, given that this is a Caucasian woman, she's relatively young, she has, the double vision, and she has bilertosis, so symmetric. The most likely diagnosis in this case is going to be myasthenia gravis, right? And so that's step number one. And then based on that, what is the most appropriate diagnostic test? Well, then that's going to be, short-acting idurifonium, which is a acetylcholinesterase inhibitor. That's the or the tensilin test. That is the classic test, but it is fading. It's not really being used all that much in the U.S. It's still used in other parts of the world. At least in the U.S., we tend to use anti-cholinesterase antibody assays. But again, that's a simple example, a two-step question that forces you to think about the pathology, step one, in the diagnosis, and then step two, the diagnostic test. All right. So, at this point, I am, you're going to ask yourself, hey, how do I dissect a question? And so I'm going to pass it off in just a bit, but basically to Daniel. But what Daniel's going to be talking about is he's going to talk about how do you dissect a question? How do you kind of understand the clinical vignette, the lead-in, the cardinal signs, confirming rejected diagnosis, and the reviewing answer choices. So Daniel, I'm going to pass this off to you. Daniel, you there?
Yes, sorry, I had it muted. So yeah, the first thing we want to talk about is just kind of how questions are set up. So they're set up with a stem and then a lead-in, and then your key and distractor. So the stem is just the question itself, or the vignette. So that's the vignette, the first thing you come to and the first thing you read. The lead-in is just the question itself. And the lead-in can vary, drastically. It can be anything from what's the most likely diagnosis to what's the next best step in management to, what is the mechanism of action of, said drug or, said disease state. So all these kind of things that can, show up there. The key is the correct answer, and then the distractors are just the wrong answer. So it's nothing more than that when we kind of talk about the anatomy of a question. Advance the slide for us. Great. So if we were to label this question and just to see kind of what is the stem, the lead-in, the key, and the distractors, we've actually got it color-coded for you here in just a second. But the stem is just the, the large part there. It starts with a 38-year-old woman that comes in for the evaluation of chest pain. The lead-in is, once again, the question itself, which can come in many different shapes and forms. And this one asks for which of the following laboratory tests will be used to monitor the patient's condition. And again, remember, this can be, a diagnosis, a treatment, a physical exam finding, a management step. Can really vary from anything to anything. And then the key is the correct answer down there, and then the distractors are just all your other wrong answers. And if you click forward one, we'll see the color-coded version. There we go. So the key here would be the platelet count, and the distractors would be just all your wrong answers, which are colored blue there. And then this is just kind of question anatomy and how questions are set up. So the next thing I really want to talk about is how I approach questions. Now, the thing that I'll tell you is it really doesn't matter so much how you approach a question, but just have a method and use it. It's kind of like reading chest x-rays or reading ABGs. If you have a specific way that you'll go about it, just go about that specific way every single time so you don't make mistakes. The way I ended up doing it, I kind of spent some time and created my own method and all that kind of fun stuff. But the way I did it was I started with the lead-in, which once again, that's the question itself. So what are they asking me? And the reason I did this is I wanted to know what I was being asked. Then I actually looked at the answer choices, and I kind of thought about each answer choice. So what would the question and the stem need to say, or what would the vignette need to say to make me pick answer choice A, or to make me pick answer choice B, or to make me pick answer choice C? Then I would read the question of the stem, and that's just the large block of text. From there, I would eliminate wrong answers, and, and eliminating wrong answers is maybe not the best wording there, but what I would do is look at the answers and say, okay, why do I think this answer is right or wrong based off the information that I've been given in the STEM, as well as looking at the question that they're asking itself. Then I would pick an answer, and I'd pick the best answer based off the knowledge I had and the information that I applied to that point. And at this point in time, I have move on. And what I mean by that is, at this point in time, you've applied a process to this question. You've given yourself the best chance to get the question correct. And usually spending more time here is not going to increase your chances of getting it right just by staring at it longer. And so this is kind of my checkpoint to say, hey, I've done what I needed to do. I went through my method. I went through my process. And now I'm just going to move on to the next question and, basically forget this question so that I can apply the same process, the same method to the next question without anything holding me back. So, all right, and this first question we're going to work here, I'm going to just show you how I would go about it. All right, so we're going to start off, and like I said, the first thing I do is just read the lead-in or the question itself. And here it says, an analog to which of the following hormones may decrease this patient's abdominal pain? So what we're about to be looking at is analogs to specific hormones. So I would expect to see hormones down here. And then we'd look at the answer choices. And what we would see is we have a bunch of different answer choices. So we have cholecystokinin. And what cells make cholecystokinin again? Well, that's made in the eye cells of the duodenum and the jejunum. And what does it do? Well, cholecystokinin acts to increase pancreatic secretions and gallbladder contraction. So we have the pancreas and gallbladder contracting, and it's made from the eye cells, and that's cholecystokinin. Now, how about gastrin? What does gastrin do? Well, gastrin acts to increase gastric hydrogen acid secretion and increase gastric motility. And where's it made again? There you go. It's going to be made from the G cells of the antrum of the stomach. So then I'd move on to the next one and say, okay, now secretin. Where's secretin made? Well, secretin's made from the S cells of the duodenum. And what does secretin do? Well, secretin leads to increased secretion of pancreatic bicarb. So our first three answers here, we're kind of seeing a trend. So, we have increased pancreatic secretion, increased gastric acid secretion, and then increased pancreatic bicarb secretion. So now we get to somatostatin. So where's somatostatin made? Well, somatostatin is made from the D cells of the GI mucosa as well as pancreatic islets. And what do we think that, or what does somatostatin actually do? Well, it leads to a decrease in gastric acid, pepsinogen secretion, as well as a decrease in fluid secretion. So this one is something different. So we have three increases and now a decrease. And then we look at, vasoactive intestinal peptide, and we think, kind of where's it made again? And it's made in the parasympathetic ganglia. And then we'd say, okay, now what does it do? And it leads to increased intestinal water and electrolyte secretion. So once again, we got another increase. So if we just had to kind of make a random, stab at this question, we could make a random correct stab by just picking the one that's not like the others. But with all that, I would say, okay, now I know what I'm talking about, what my question is going to be asking me about, and I know at least as much as I can about my answers. So then I would read the question itself. All right. Now our question here says, we have a 62-year-old man with a history of chronic alcoholism who presents to the emergency department with abdominal pain. On questioning, the patient reports he has loose stools that have been difficult to flush over the past several years. However, these symptoms have recently worsened. On CT imaging of the abdomen, or a CT image of the abdomen is shown. That's our picture down there. And the intern on duty has previously learned about the treatment that may benefit this patient. All right, so now from this point on, just take a look at the question itself, the stem, the image, and think about which answer you want to pick, and then we'll do a poll.
All right, so we'll give you guys a minute, and then I'm going to open up the poll. All right, I am going to open the poll, so hopefully you guys have locked in on an answer. And I am going to launch the poll now, and then you get to choose your answer, A, B, C, D, or E. All right, here we go. So you should have the poll in front of you. You think it's A. If you think it's cholecystokinin, pick A. If you think it's gastrin, pick B. Secretin, pick C. Somatostatin, pick D. And then vasoactive intestinal peptide, picky. Right, looks like about 20% of you folks have answered. I'm going to wait a couple more seconds. Some of you folks might, be looking for the Q&A panel. Again, if it's on a PC or Mac, it's going to be, generally on the right side. If it's on your iPad or your Android phone or whatnot, it's going to be, in the menu bar, typically at the top. All right, looks like most folks have answered. I'm going to go ahead and close the poll in a second. Wait for a couple more answers to come in. All right, here we go. I'm going to share the poll response, and what we see here is that the majority of folks have chosen somatostatin. A couple of folks are thinking vasoactive peptide and cholecystokinin. So those seem to be the three most popular answers. All right, so I am going to hide the poll, move on to the answer, and the answer is D, somatostatin.
All right, great. So the answer here is somatostatin, which is D. And so this guy we have a question here that's describing, the pancreatic dysfunction, which is secondary to this patient's chronic pancreatitis. And if we were looking back at that image, we'd actually see that, pancreatic calcifications, and that along with his, steatorrhea and chronic abdominal pain would be consistent with, the diagnosis of chronic pancreatitis and then this pancreatic dysfunction. So now what med is somatostatin an analog to that may help this patient's abdominal pain? Anybody think of that? There you go. That medicine is octreotide. So octreotide is the analog to somatostatin that can be given to potentially decrease his abdominal pain. And how is that all going to work? Well, octreotide, being that analog, will act to decrease gastric acid and pepsinogen secretion, as well as decrease fluid secretion and decrease gallbladder contraction. And it does all of this by decreasing gastrin, cholecystokinin, secretin, and VIP release. So somatostatin itself acts to decrease all of those other hormones. Now, what's something else that we can use octreotide for? And a hint here is this disease actually leads to increased sizes in your hands and your feet. There you go. It can be used in acromegaly. So remember, octreotide can be used in acromegaly. So acromegaly is due to secretion of too much growth hormone, and octreotide works by inhibiting the release of growth hormone. So now let's walk through this table. So the thing that you want to know here is when they ask you a question, similar to this one, is that, just knowing the correct answer here, which was somatostatin, may not be all that you get asked, or may not be the only thing that you could be asked in relation to this question. They could have written it in a way in which you had to know which cell was released, or which cell secreted, the somatostatin. They could have asked it in a way, that, gastrin was the right answer, cholecystokinin was the right answer, or secretin was the right answer. They could have asked it and made you know that, which regulator, so what leads to the increase in gastrin, what leads to the increase in somatostatin. So let's walk through all these, real quick right here. I know we did a little bit of it, so we'll try to move kind of fast. So gastrin, now where's gastrin made? There you go. It's going to be made from the G cells, and that's made in the antrum of the stomach and as well as the duodenum. And its actions, they're going to be to increase gastric hydrogen ion secretion, as well as lead to growth of the gastric acid mucosa, and also lead to increased gastric motility. So what do you think regulates it? There you go. Stomach distension is the main thing you need to know there. There's a lot of other stuff there, but stomach distension is the main thing. So when you fill your stomach up, gastrin is released. It's also decreased if the pH gets too low. So if the pH decreases, you lead to a decrease in gastrin, but it's increased by stomach distension. Some of the key facts that you need to know is that gastrin is classically elevated in chronic PPI use. So if you get a question where they ask you about, what's the potential cause of this patient's elevated gastrin level, everybody always wants to jump over Zollinger-Ellison syndrome or gastrinoma. So, they have an elevated gastrin and you want to pick gastrinoma. But remember, that's not very common. That's a 1 in a million diagnosis. So if it asks you what is the most common cause, it's probably just due to chronic PPI use. That'd probably be the most common cause. Now, if they have like jejunal ulcers and, you're taking them off their PPI and you still have a gastrin that's, 10 times the upper limit of normal or 200 times the upper limit of normal, yeah, Zollinger-Ellison syndrome is a legitimate thing that it could be. But just remember, your common things being common there. So now moving on to somatostatin, which was our correct answer here. Now it's made where again? There you go. It's going to be made in the D cells, and those are in your pancreatic islets as well as your GI mucosa. And its actions are going to be to decrease gastric acid, as well as decrease pepsinogen secretion, and then decrease pancreatic and small intestine fluid secretion, as well as decrease gallbladder contraction, and then decrease insulin and glucagon. So once again, when we look back to our question, which was basically all of these answers, which increased, GI motility, gastric acid release, pancreatic secretion of something, somatostatin was our right answer here because it led to a decrease in all those things. Decreasing all those things led to the decrease in abdominal pain. So what do you think the regulators are? There you go. Increased acid is going to increase somatostatin release, and then decreased, you're going to get decreased somatostatin release by your vagal stimulation. So if you have vagal stimulation, then you're going to get decreased somatostatin release. Some of the, just kind of keynotes to think about are that, octreotide is an analog of the somatostatin, kind of like we already talked about, and it can be used to treat acromegaly, as well as carcinoid syndrome and then varicose bleeds. And remember, somatostatin or octreotide works in varicose bleeds to decrease your portal pressures. So that's kind of the mechanism there. Now moving on to cholecystokinin, it's released by your eye cells, and your eye cells are found in your duodenum and your jejunum. And once again, if they're writing a question, they could ask you, hey, what is the location of the eye cells? And you would have to say duodenum or jejunum, or they could say, what cells release cholecystokinin? And in that case, you would have to say, your eye cells. These are going to lead to increase, or cholecystokinin is going to lead to increase in your pancreatic secretion, increase gallbladder contraction, decrease your gastric emptying, and then increase your sphincter of OD relaxation, so that more of your bile is able to leave your gallbladder and end up into the duodenum itself. So this cholecystokinin is increased by fatty acids and amino acids as they enter the stomach. And then some of the keynotes here are that acts on the neuromuscarinic pathways to cause pancreatic secretion. So just kind of muscarinic pathway there. That sometimes they can tie that in there, going back to even your kind of pharmacology type stuff. Now for secretin is released by your S cells, and once again, those are found in your duodenum, and this is going to lead to an increase in your pancreatic bicarb secretion, as well as decreases your gastric acid secretion and increases bile secretion. Once again, secretin is increased by acids as well as fatty acids in the lumen of the duodenum, so not so much the stomach, but in the lumen of the duodenum itself. And then some of the key notes to note for secretin are that it is the increased bicarb actually neutralizes the gastric acid in the duodenum. So remember, as acid from your stomach gets released into your duodenum, the secretin is going to be increasing, which is going to increase your pancreatic bicarb secretion. And remember, the secretion of your bicarb is what neutralizes the acid from your stomach so that your pancreatic enzymes can work. Because the pH is too acidic, it actually just kills or neutralizes all the enzymes that your pancreas has been working to release. And then now moving on to vasoactive intestinal peptide. So what's it released from again? It's going to be the parasympathetic ganglia and the sphincters, and as well as the gallbladder and small intestines. So mainly your parasympathetic ganglia there. What's it act to do? It acts to increase intestinal water and electrolyte secretion. So basically inducing more fluid into the small bowel itself, as well as works to relax the small intestine smooth muscle and sphincters so that things can kind of move along. It's increased by distension as well as vagal nerve stimulation. So if you have distension of the small bowel, you're going to get increased vasoactive intestinal peptide, as well as if you have vagal stimulation, that's going to lead to increasing your vasoactive intestinal peptide. And then your adrenergic input will lead to a decrease in your vasoactive intestinal peptide release. So if you get, if you're running from the bear in the woods that's trying to eat you, you're going to have increased adrenergic input, which will lead to a decrease in your vasoactive intestinal peptide release. Same goes for exercising, same goes if you were wounded, those type things. And then some notes on it. Basically, they just want to talk about the VIPoma, which is something we at least all need to know for test purposes. And this is a non-alpha and a non-beta islet cell pancreatic tumor that secretes lots of vasoactive intestinal peptide, and it leads to watery diarrhea, hypokalemia, and achlorhydria. And it can be remembered by the acronym WDHA. So, all right. that will wrap up that table, and we can move on, I believe, to the next question. Okay, good. So we'll just kind of work this question straight from the top, just as we normally would, any question we run across. And just a kind of aside, this is a tough question, so we'll jump right in. So we have a 58-year-old man that's referred to the cardiac clinic because of progressive weakness and cough, as well as shortness of breath. He has a history of some coronary disease. He was started on hemodialysis 5 years ago because of end-stage renal disease. At that time, he had an AV fistula that was constructed for access. He has a pulse that's 97, blood pressure that's 115/68. On cardiac auscultation, a systolic murmur is heard over the apex that does not change in quality with physical maneuvers, so physical exam maneuvers. So they do some physical exam maneuvers, hand grip, whatever you want to call it, make him stand up, make him squat, and there's no change in the murmur. Which of the following changes in the left ventricular pressure volume loop most likely reflects this patient's hemodynamic status? And remember, the black line indicates normal. So would it be A, B, C, D, or E?
All right, so you guys take a minute, think about the clinical presentation, and then think what are the pressure volume loops matches best. All right, so I'll give you guys a second, then we'll go ahead and open up the poll. So here we go. So hopefully you have a letter in mind corresponding to the flow volume loop, and here we go. A, B, C, D, or E. All right, looks like about 10% of you guys have answered. We'll keep this open for a little bit. It's probably going to take 15-20 seconds for folks to put in an answer. A couple more seconds. We're up to about 50% here. Don't be shy. We don't know who you are. Just give it your best shot. All right, looks like we got enough answers. So I'm going to go ahead and close the poll and share the answers that you've given me. And you can see that the most popular answer is B, followed by C. And then, there's a spread over all the other flow volume loops. Pressure volume loops. So this one was a challenging question. So let me go ahead and drop the poll, and let's get back to this and then see what the actual answer is. And the answer is B. So about 30%, 35% of you folks got that right.
All right, great job those who got it right. Yeah, this was an extremely tough question, and limited amount of time to kind of work it there. But to completely understand this question, I feel like we need to understand a good bit about cardiac phys. So we're going to take a look at an image from your first aid book. Advanced slide. There we go. Okay. So this image can be found in your first aid book, and it's just a pressure volume loop. And you have your left ventricular pressures here on the y-axis, and on the x-axis you have your left ventricular volumes, and you can see your end systolic volume kind of designated there on the left-hand side, and then your end diastolic volume kind of designated there on the right-hand side. So if we start out here at 1, we can see isovolumic contraction. So this is whenever all your valves are closed, but the left ventricle is contracting, trying to get blood out, but nothing's opened. So here you would not expect to see a change in volume. And if you look at kind of the direction of your line there, it's going straight up. The volume's not changing, it's not moving to the right or the left, but your pressure is going up. And then you can see that kind of designated from the bottom part of that line to the top part of that line. Then after this, after the left ventricle has generated enough pressure to open the aortic valve, you kind of move into 2, which is your systolic ejection. Here you're going to see that volume is actually being ejected from the left ventricle into the aorta, and we can see a fall in your left ventricular volume as you move from right to the left on this curve. Eventually, the pressure in your left ventricle is going to fall below that of the aorta, and that's going to lead to your aortic valve to close. When your aortic valve closes, that's when you will hear your S2. And this will start the isovolumic relaxation phase. And this is when the volume remains constant, but the pressure is starting to decrease. So pretty much the exact opposite of isovolumic contraction. So then the next thing that's going to happen is your mitral valve is going to open, and your left ventricle is going to start to fill. And as it fills, it's going to be increasing your volume. So you will see, you're going to move from left toward the right on your curve here. And then once it gets pretty much full, you're going to end up seeing your mitral valve close, which will then lead to your S1, and then this will kind of start the whole process over again as we enter isovolumic contraction. And so taking all of that in mind, I want to look back at the curve that we just had on our question, and we're going to end up kind of talking through that. Well, let's just stay right here. So let's just stay right here. Well, sorry about that. Would you go back to that? There we go. Okay, so taking all that in mind, we want to talk about what would happen if we increased or decreased preload, or increased or decreased afterload, or even contractility, and how it would adjust this curve. So if we increase our preload, this is going to lead to an increase in our end diastolic volume. And you can see our end diastolic volume there kind of on the bottom right-hand side. So if you increase preload, it's going to move everything that direction. So what do you think would be a few things that could actually increase your preload? So good, that'd be something like giving an IV fluid bolus, or performing a straight leg raise, or even just laying someone down if they were standing up. So taking someone and going from the standing to the lying position. So now what do you think would happen if we decrease preload? Well, if we were to look at our curve here, it would actually move to the left. So it would move toward your end systolic volume or away from your end diastolic volume. It would just kind of shift to the left there. So instead of shifting to the right when you increase preload, it would shift to the left. And what are a few things that you would think would actually decrease your preload? Good, these things would be like dehydration or bleeding, maybe from a GI bleed or from some form of trauma. So we have things that increase preload, like giving an IV fluid bolus, and we have things that decrease preload, like someone exsanguinating after they've been shot. Now we want to look at afterload. So what do you think are some things that would increase afterload? Well, a few things that could increase afterload would be maybe something like aortic stenosis or just systemic hypertension, and then even the hand grip maneuver. So, but how would we expect our curve to change if we increased afterload? Well, if you increase afterload, then that means it's going to require more pressure to actually get blood out of the left ventricle. This is going to increase the time in your isovolumic contraction phase. And the thing to note here is that, remember, your time in your isovolumic contraction phase is the time of the highest oxygen consumption. So if we spend more time in this, isovolumic contraction phase secondary to hypertension, you're going to actually really be stressing the left ventricle a lot. This can lead to, your cardiomyopathies, as well as, your cardiomyopathies that you see secondary to long-standing hypertension and those types of things. So in terms of, when the ventricle begins to relax, it's also going to lead to premature closure of the aortic valve, because once again, the pressure in the aorta is higher than that in the left ventricle, which leads to closure of that valve. And all of that's going to lead to a decrease in your stroke volume, which is once again just the, if we were to look from one side of our curve to the next side of our curve, that's going to be a decrease in our stroke volume. Or to think about it another way, we would have an increase in our end systolic volume. So the volume in the ventricle at the end of systole would be higher, which would, be because there's just more blood around at the end of systole. Now, moving on from there, what do we think are some things that would lead to a decrease in our preload, in our afterload? So this would mean that if we have a decrease in afterload, it would be easy to eject blood from the left ventricle. So since we have a lower pressure to eject blood out, we'd be able to eject more blood out. And so as we squeeze, as you have a contraction, you're able to get more blood out, and that means that you're able to end up with a lower end systolic volume and actually increase your stroke volume. So as you decrease afterload, you would expect to see an increase in your stroke volume and a decrease in your end systolic volume. And can you think of a few things, or can you think of something that would lead to a decrease in your afterload? There you go. The classic example here is, your amyl nitrate. So if you ever get a exam question asking, what's something that decreases afterload, amyl nitrate ends up being the answer that they like to look for there. Now, last but not least, looking at contractility, If we had an increase in contractility, this would mean that more blood is ejected from the left ventricle at that same given pressure. So meaning that if, all things being equal and the heart just squeezed harder, you would get more blood out per contraction. So if we were to think once again in terms of stroke volume and in terms of in-systolic volume, our in-systolic volume would go down and our stroke volume would go up if we had an increase in contractility. And can you think of something that would increase contractility? And particularly, can you think of a medicine that would do it? There you go, digoxin. Digoxin is kind of a classic example that leads to increased contractility. And then what about decreased contractility? What would decreased contractility do? Well, if we think about it in terms of stroke volume, and again, is in terms of your in-systolic volume would go up and your stroke volume would go down. So there would be more blood left in the heart after each contraction, just because the heart's not squeezing as hard at the same given pressures. And can you think of a good example of something that would decrease contractility? And a good example there would be just classic heart failure, particularly systolic heart failure or heart failure with reduced ejection fraction, kind of depending on what terminology you want to use there. So going back to, now you can advance the slide. Sorry about that. So going back to our graph here, we can see that our correct answer, like it talked about, was our graph B, or choice B there. So why do we think this is? Well, in this question, they give us a patient that has an AV fistula for his dialysis. So what is this AV fistula going to do? Well, the AV fistula itself is going to lead to increased blood return to the heart because blood's going to be shunting from the arterial to the venous system. This is going to increase our venous return and therefore increase our preload. So we're looking for an answer that has increased preload. And if you look at our answer choices here, is it going to be what curve that's going to be? There's only two curves that have increased preload, and that's curve B and curve C. So looking at our curves, we have curve B and curve C. Those are the only two possible correct answers. All the other answers kind of eliminate themselves. So then going on from there, because of this, this shunt, we also have a decrease in our afterload. And this is going to be because the blood is going to be bypassing the arterioles, which is going to lead to a decrease in your total peripheral resistance, which will lead to a decrease in your afterload. So we're looking for an answer that has an increase in the preload and a decrease in the afterload. So if we do that, you can see that the afterload is lower for curve B, and that the afterload is actually either the same or unchanged, and except for curve E, which has gone up for all the other curves. So once again, that in itself also eliminates all the other answers. So that only leaves one good answer left, and that's curve B, which is the curve that suffices to show that there's an increase in the preload as well as a decrease in the afterload. Remember, if we decreased afterload, we expect more blood to be ejected from the heart, which would increase our stroke volume as well as lead to a decrease in our in-systolic volume. So once again, that's how we ended up at our answer choice being B there, which once again is very, very difficult, a lot to walk through, but that's how we get the right answer. All right.
Great, and Dan, I think also you can see that there's the decrease in systolic volume, right? Which is, I think with AV fistula you can get increased contractility rate because you're just pumping a lot more blood. Is that right?
Yeah. Yes. Yeah. So the in systolic volume is definitely going to go down. Which partially due to the decreased afterload as well as just the high output state that it can help generate.
Right. Great. All right.
All right, moving on to our next question. So here we have a 10-year-old boy that is brought to the pediatrician because he's been vomiting every few hours for the past 2 days. He denies any recent travel or contact with sick persons. He has a history of asthma, which is well controlled with 2 puffs of salbutamol per day. His temperature is 98 degrees Fahrenheit or 36.7 degrees Celsius. His blood pressure is 99/65. His pulse is 88. Respiratory rate's 10, oxygen saturation is 92 on room air. On exam, he appears lethargic and uncomfortable. However, there's no wheezing appreciated on lung exam. His abdomen is soft and non-tender. Which of the following sets of laboratory values shown in the table would be most likely to be found in this patient? We have choice A, B, C, and D. And for A, we have a pH that's less than 7.4 with a low PCO2 and a low bicarb. For B, we have a pH that's less than 7.4. and then a high PCO2 and a high bicarb. For C, we have a increased pH above 7.4, a low PCO2 and a low bicarb. And then for D, we have Once again, the pH is greater than 7.4, low PCO2 and high bicarb. And then for our last one there, choice E, we have an increase in our pH above 7.4, and then PCO2 that's high as well as bicarb that's high.
All right. So take a look at these choices for pH, PCO2, and bicarb. Lock in on an answer, and I will go ahead and open the poll. So we'll just give you guys a couple seconds since there's a couple of choices to look at. All right. Oops. Wait a minute. Let me get that right. Let's go ahead and launch the poll. All right. We'll leave it open for a good 30 to 40 seconds. Looks like about 30% of you folks have answered. We'll leave it open for a couple more seconds. Go ahead, and if you don't have an answer, just go ahead and take your best educated guess. Chances are at least some of you folks will be at least partially right. All right, looks like we've got close to 3/4 of you folks have answered, so I'm going to go ahead and close the poll and share the response. Okay, so I'm going to share here, and what we see here is the two most popular answers are E followed by D. So a lot of folks are saying high pH at the very least, and thinking high bicarb. So let me go ahead and hide that, and let's move on to the next slide. If I can get this minimized here. So the answer is E, high pH, high PCO2, and high bicarb.
All right, so good job, good job. So the answer here is E. And so what exactly is E showing? Well, once again, the pH is elevated or greater than 7.4, which is alkalotic. And we also see the high PCO2 and as well as a high bicarb. Kind of going on from there, is this a metabolic or is this going to be a respiratory alkalosis? Well, it's going to be metabolic alkalosis. And why do we think this is? So why does this patient have a metabolic alkalosis? Well, the question itself talks about the kid having a lot of vomiting. And this is going to lead to loss of hydrochloric acid from the stomach, and it will also contribute to an alkalosis. So just because they're vomiting up a bunch of acid will lead to an increase in the bicarb, just because there's nothing to compute there. Also, you can see a lot of volume loss when you get a lot of profuse vomiting. This is going to lead to the kidneys trying to retain all the fluid and electrolytes they can, which will result in bicarb retention. And this is kind of classically called, your contraction alkalosis that you can see in dehydration. So that, along with the fact that you're throwing up all your acid, is going to lead to an alkalemic state or a pH greater than 7.4 and a bicarb that is elevated. If we look at the PCO2 itself and say that it's high, well, this is because the respiratory system is trying to compensate for the elevated pH. Remember that your CO2 in serum kind of acts as an acid, and it's going to, in this case, work to try to correct the pH back down toward normal, which is 7.4. And remember, it's not able to do it perfectly, but it's going to work the best it can to get it down. So looking at our other answer choices, choice A and choice B show an acidosis, not an alkalosis, and we're looking for an answer that shows an alkalosis. So it kind of eliminates choice A and choice B. When we look at choice C and choice D, why are these wrong? Well, these both show a PCO2 that is low, and we would and that's seen in a respiratory alkalosis. And we're expecting a metabolic alkalosis here. So seeing that those are both are in a respiratory alkalosis, that makes those wrong, and that only lives with choice E here, which is right, which is consistent with our contraction alkalosis secondary to our vomiting, and our PCO2, which is trying to compensate. And I believe that is our last question for the evening. And I personally feel that these were probably the 3 hardest questions we've had on our question dissection kind of webinar so far. So thanks for everybody for participating and just hanging in there on these tough questions.
All right, very good. So let's go ahead and wrap things up here. So let me see. Let's go back to 18. So So Dan, you want to go ahead and take it home here with the dissection tips?
So, my first and, I feel main dissection tip is just to have an approach. Once again, just like if you were looking at a chest x-ray, or if you were looking at an ABG, or, whatever how you approach chest pain workups, however you want to look at it, just have an approach, have a way that you go through questions. It doesn't have to be, the way I talk about, or it doesn't have to be the way that, someone else suggests. Just, create a way that you're on and do that every single time. The main thing here is just, decrease those careless mistakes. Make sure that you're not missing, keywords and key information. Moving on from there. Next thing is just to know that each question has a format, which is, a stem, a lead-in, the key, and then the distractors. And just remember, if you see like a picture that's not, related to what you feel like the stem's related to, the stem is going to be more important than, your picture in your labs. So just always kind of drive everything through your stem, or your your vignette there. Once again, when you're selecting information, utilize all the information that's provided. That's even including the other answer choices, or the distractors. Sometimes the other answer choices themselves kind of are tips, or keys to what is the actual correct answer. Don't look at any one piece of information in isolation. Use all the information they've given you in the clinical setting and scenario that they've given it, and help all that stuff to kind of lead you to your right answer. And remember that each question is created with to test a set of related topics and content areas. So when they write a question, they're writing it on, I want to test the student on metabolic alkalosis diagnoses, or I want to test the student on cardiac physiology, pressure volume curves. And if you realize that they have a specific topic and content area in mind that they're trying to test, sometimes that can help you, kind of hone in on an answer. Oh, they're probably trying to test me on this, so that makes A more likely to be right than C. So.
The only thing I'll add to the excellent advice that Dan's giving you, that is, especially as sometimes we're seeing stems that are getting a little fatter, that have more detail. Sometimes they will provide extraneous information. You'll have to kind of be able to discriminate on what is useful information, like a good clinician, to put together the picture. So while you do absolutely have to review all the information, sometimes it's just a subset is what you need to actually make the diagnosis. It's also possible that they'll give you diagnostic information that is tied to a comorbidity, right? So, in that particular case, they might give you something if the patient had active asthma, whatnot, but it may not be all that related to what's actually going on with the vomiting and the contraction alkalosis and the PCO2 correction. So just keep it in mind, that it may be true, but not related to the condition that they're trying. So you'll pick that up as you obviously do more questions, and you'll improve your discrimination over time. All right, and then in terms of just general study advice, for those of you folks who've seen my other talk about the path to 250, there's a couple of things that students have found to be really helpful when preparing for the boards. One is you need to plan well in advance, and you want to kind of think through what your goals are. And so once you do that, once you develop a study schedule, and once you have that reviewed by classmates or colleagues or folks who've gone through the boards, and can provide some of that type of advice, you should be able to stick with it, as long as you properly plan things out, and as long as you follow some of these other rules. Okay. As you saw with the questions that Dan went through, the questions on the board can be complex. They can involve multiple concepts. So when you study and when you think about applying these as questions, remember, try to integrate and apply everything, because almost anything can be connected to other concepts, and that's how the board loves to set up these questions. Give you a little pathology, then make you think about the treatment. A little pathology, think about the underlying disease, or some sort of outbreak, and then you have to use some epidemiology to solve what kind of outbreak it is, and so forth. There are certain crammable subjects that tend to work better towards the end. We don't advise that you cram. We advise that you study deliberately, that you test yourself and so forth, and that those are ways to really learn and retrieve those memories and apply those memories. But towards the end, especially in the week or so before the boards, you might be able to cram a couple of things such as metabolic pathways, some high yield micro tables. Same thing with pharmacology as well too, because they tend to be the content there tends to be repetitively structured, i.e. they always ask about the same things, right? If it's drugs, it's always about the indication, the mechanism of action, the side effects, that type of stuff. Do take advantage of what you previously learned, right? So you've gone to med school, or you have gone to med school, and and the USMLE is supposed to be testing all that. And so you can match that up with what you see in high yield resources like first aid. Focus on those things first, then go to other high yield material that may not have been as well covered in your school or in your curriculum. As I mentioned, if you do these things, if you don't overschedule, as if you try not to try not to study more than 10 to 12 hours a day. If you give yourself off at least a day off a week, especially during the dedicated study time. If you give some time for you to get some exercise, spend time with family, loved ones, and so forth, you shouldn't have to upend your study schedule because you missed something or whatnot. I often advise that you try to get through your primary studying, even during your dedicated with about a week left to go. So during the week left to go, then you can mostly use that time to focus on a couple of areas where your testing shows that you still have weaknesses, and to continue to self-test. In first aid, we do advise that, again, if you plan in advance, you can kind of keep the long view in mind. It'll help you stay relaxed and understand the exam for what it is. It's just an exam. It's not a measure of who you are or for the rest of your life or what kind of doctor you are. In fact, the evidence says that it doesn't really do a good job predicting what kind of doctor you'll be. It just happens to be an exam that you do have to pass, and unfortunately, it does have some bearing in terms of applying for residencies. But once you're in there, that exam doesn't have really any type of bearing on what type of doctor you'll be or what kind of resident you'll be. All right, so as I mentioned, you can find us on social media. We're on Facebook @/USMLE-Rx. You can go to our blog at firstaidteam.com. You can also follow us or at First Aid Team, both on Twitter and Instagram. So happy to continue the dialogue there. All right, and finally, as I mentioned, we're going to raffle off a couple of RX 360 subscriptions for 6 months. That includes access to our flagship question bank. That's 2,300, exceptionally well-written questions with deep explanations, that students prefer even to other question banks, top question banks out there. 14,000 flashcards and 1,300 videos that are all linked to first aid, as well as access to first aid. So the two winners of the raffle are Karen Sierra and Ethan Abdi. So Karen Sierra and Ethan Abdi, if you are still on this webinar, I need you to type into the Q&A box that you are there so that we can recognize you and make sure you get your raffle prize. Karen Sierra and Ethan Abdi, are you guys there? All right, I see Karen Sierra, congratulations. Is Ethan Abdi there? All right, Ethan, if you're not there, then we will move on to the next person. And, Ethan, I'm sorry, Elhan Abdi. That must be it. Luis, I think that's correct. Elhan Abdi, not Ethan Abdi.
That's correct.
All right.
It is correct, sir.
All right, thank you. Okay, so Elhan, I'm sorry about the typo there. All right. Well, congratulations. Louise will be in touch with you, about your raffle prizes. For the rest of us, we do have a special offer for you guys. You can get 25% off today and tomorrow only to our question bank, step 1, flash facts, our videos, or the whole RX 360 package, which is the best deal, using the promo code April Showers on checkout. Just note that this is good till midnight tomorrow, and if you're on a free trial, it's not, the free trial won't extend the offer, and it doesn't apply to the RX bricks. That's our curriculum bricks, or any extensions or renewals. So just keep that in mind. All right. So with that, I think we are pretty much at the end of the discussion. We got a couple of minutes, and happy to take on any questions. So I'm going to ask Manaver and Sean to help identify thematic questions, that you folks were really interested in, and see what we can discuss together.
Tal, there were a few questions where students were asking about study techniques, study schedules, which question banks they should be using.
Okay.
That's what I saw. That was quite repetitive.
Gotcha. So what I would suggest is you go to our blog. Let me see if I can get to our blog. This is right here. This is our first Facebook page. You can obviously follow us there. But you go to our blog, firstaidteam.com. What you'll see is you can get our other presentations, particularly the Path to 250. That will cover a lot of those questions. So there's both a PDF to the presentation, which you can see here. So that will give you a lot of information about prepping for the USMLE, particularly if you need to score well. And also there is a video as well too of that talk. So it'll talk about that and talk about choosing resources and so forth. We do have a set of resource guides here, and so that would be under the bonus study stuff. So you click bonus study stuff, you can go down here. You can get the for free our top rated review resources, and in this PDF, it will give you ratings for top question bank, video resources, apps, books, and so forth. So do check that out. All right, other questions?